Hello. Thank you for being here. You guys are here for the diabetic neuropathy talk. Just going to introduce our speaker today. Dr. George Banks is a neurologist at ANMC, Alaska Native Medical Center. He completed his neurology residency at the University of Washington, followed by a neuromuscular medicine fellowship at Oregon Health and Science University, which is a subspecialty of neurology focused on the peripheral nervous system. He's board certified in both neurology and neuromuscular medicine through the American Board of Psychiatry and Neurology. He is currently working in general neurology with a specific interest in NCS, EMG studies, as well as neuromuscular disorders. Please help me welcome Dr. Banks.
Sorry, everybody, for the brief delay. I'm just switching over to one of my colleagues to cover call for the hospital. But yeah, it's nice to meet everybody. Thanks for coming out, and thanks for the introduction. I understand everybody here's from different backgrounds. I was just curious if people could briefly shout out what background of medical training they have or no medical training, and just curious. Okay. 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 Any podiatrists? Nice. Figured we'd have at least one. All right. So I'm going to get started on this talk, which I've tried to make just an overview of diabetic neuropathies. I hope it doesn't go over the top with explaining things. And please interrupt at any point if you guys have any questions for me. I'm always open to questions. I apologize in advance. I'm a photographer and outdoor enthusiast, and I didn't include any good pictures in this to keep it entertaining. So it is going to be very dry, and I'm sorry. You all already know this, that diabetes is very common. And if my percentages are incorrect, please let me know. But approximately 10% of Americans are known to have diabetes. About half of those will develop neuropathy. And I think that many of them don't have any reported symptoms, so it's diagnosed clinically or something that's an incidental finding they weren't aware of. Neuropathic pain is common, and we see a lot of neuropathic pain in neurology, but I suspect there are many, many patients that we don't see because they don't come in saying that their feet hurt all the time. And that usually is what brings things to our attention. Really brief, I promise I'm not going to go into this in very much detail. Fortunately, I don't think we understand the pathophysiology all that well either, so that helps. But basically, when we look at the nerves, the nerve fiber are surrounded by tissue that's called the endoneurium. There's a significant blood supply that travels in this space underneath the perineurium, between the perineurium and the endoneurium, and it supplies the nerve fibers. This collection of nerve fibers is called a fascicle, and those are all wrapped with epineurium, which has its own separate blood supply. And then over here, we have this little picture of the sympathetic nerves that travel along the blood vessels and are involved in some of the responses for sweating and other skin changes that are seen. Generally speaking, distal nerves that are far away in our feet are the first to be affected. And the etiology, we think, is a combination of many different things. These were, I think, the highlights, that there's a role of neurovascular impairment like there is with retinopathy and nephropathy, and that oxidative stress to the mitochondria and the dorsal root ganglia drive this disease. Again, this is just another picture, and what you can see here is just a giant bundle of nerves, and the point being is that these little nerve fibers are really complicated. It's not one giant nerve. All of these tiny little fascicles bundled together that have this complex web, they mix together and are not just, again, like a simple wire that travels down the leg or arm. They're all wrapped in myelin. Myelin is like rubber for a wire that you have in your house. It creates insulation for the transmission of electrical signals. And then the axon itself, I think of as the wire. Diabetes is a distal dying back neuropathy. specifically the axons are what get damaged. And I think a lot of that is because the blood supply is coming from the outside to the inside. And so the deepest section that's furthest away from the blood supply, the axons, is going to be most affected. And it usually affects sensory nerves long before it affects the motor nerves. So just briefly talking about the physical examination that we do for anybody in neurology, and especially for diabetics. We do check cranial nerves because cranial neuropathies can occur in diabetes, different diabetic neuropathies, but obviously that's very uncommon. Motor examination. So if I'm seeing somebody for a nerve conduction study, EMG, and the question is, do they have diabetic neuropathy or do they have some other type of neuropathy? I'm usually going to just focus on the distal muscles. Usually they don't have any weakness. And so I'll start with the highest yield muscle. I'll check and see if they can extend their extensor hallucis longus, their big toe. I'll check their toe flexion, and I'll check the intrinsic hand muscles because they have such frequent entrapment neuropathies like carpal tunnel syndrome and other things that are more common in diabetes. In terms of a sensory exam, I have the luxury of a test. And so I rely on my electrodiagnostics because I do nerve conduction studies and it gives me the answer. But clinically, we should all be doing better exams, and the general guidelines for how you can diagnose diabetic neuropathy without any nerve conduction study, I've highlighted in bold and underlined. Using a tuning fork is one way. Every tuning fork's different, so I just remind everybody that a heavy tuning fork's going to buzz longer than a light tuning fork. And if your tuning fork is not 128 hertz, it's also not going to buzz as long. Usually, if you do not have neuropathy, you can use yourself as a control. So I'll usually just check myself. If somebody says they can feel the vibration for 5 seconds, I'll put it on myself and see, is it still vibrating very easily to detect? And if it is, then I think it's pretty obvious that it's impaired. Proprioception, if people are not familiar with that term, that's when you have your patient close their eyes and you grasp the end of their toe and you move it up and down and ask them, can you tell me which way your toe is moving? If they answer that correctly 50% of the time, in my eyes, that's wrong every time. They're just guessing. And if they answer it wrong every time, they're actually right and they know what their toe is doing because they can't get it right or wrong every time either. The 10-gram monofilament test, I bet our podiatrists are very familiar with, and maybe some others in here are using the 10-gram monofilament. I have never used one, but I will briefly talk about that in case people haven't. Reflexes, I bet most people in here are not checking ankle reflexes on a regular basis. And what I will say is that one of the hardest things I think for our fourth-year medical students that rotate through, and just about everybody, is they're using these little triangle reflex hammers. They're really hard to get reflexes with. And so using a little bit of a heavier reflex hammer is going to be very, very helpful for making sure that patients actually have ankle jerk reflexes. Happy to talk about that later if people have questions. But in a diabetic, if you can use that little triangle hammer and get a really obvious ankle reflex, they probably don't have at least large fiber neuropathy or peripheral neuropathy. That would be pretty unusual. Should be hard to get. And then skin examination, so painless foot ulcers, specifically highlighted as a clinical diagnostic exam finding that would allow for the diagnosis of diabetic neuropathy in someone with typical symptoms. And then some of these other findings that we think of as vasomotor and autonomic skin changes. This is the Michigan Neuropathy Screening Instrument that is often referenced in literature and in publications that talk about neuropathy in diabetes. Basically, here we've got 9 testing sites. There's another testing site on the dorsum of the foot. You're taking a 10-gram monofilament and you are applying pressure with the 10-gram monofilament for less than 1 second, and you're applying just enough pressure for there to be some flexion in the monofilament. In terms of the interpretation, you ask the patient at which sites they're able to detect that they're feeling that pressure. If they say yes, then you get a point. If they say no, or they don't say anything, then that would be incorrect. Patients should get at least 8 out of 10 correct when you do this test. Testing, so it's not always needed. I think my last slide of the lecture will talk about, I think, when we need to do tests like nerve conduction studies. Again, depends on how they're presenting. There are lots of different types of diabetic neuropathy, the most common being the distal symmetric polyneuropathy that starts in the feet, but there are other types that definitely do need other types of labs and testing. I showed a little picture of a nerve conduction study. I'm not sure if anybody here's ever had one or seen one. They're not super painful, but they're also not fun. I think often our ability to coach patients through it and talk about the fact that I've zapped myself 10,000 times often helps. Every time it breaks, nobody volunteers, so I have to shock myself and I have to call and figure out what's going on with IT. Usually the pattern that we see basically is axon loss. And so when we say axon loss, we mean that the amplitudes of electricity conducting from this cathode to this this recording electrode, that electrical signal produces a lump or a response, and that response is low. So it's not as high as it should be in diabetes and diabetic neuropathy. Sometimes they have a little bit of demyelination, which means the speeds are slower, but usually it's mostly just axonal, so they have low amplitudes of responses. Skin biopsy, autonomic testing, talk about a little bit later, but we don't rely on those very often, nor are they that necessary for the vast majority of these patients. So this is just a long table of all of the types of diabetic neuropathy. I think everybody here is probably very familiar with, I guess my mouse doesn't show up, on the distal symmetric polyneuropathy. That's the classic type, and most people, I think, that say somebody has diabetic neuropathy, that's what they're referring to. There are, however, a lot of different other manifestations of diabetic neuropathy. One of those is a small fiber neuropathy. Another one I will briefly talk about is autonomic neuropathy, diabetic neuropathic cachexia. I have 1 minute remaining. Oh, sorry. So, geez, time flies. Another one I'm going to talk about is the treatment-induced neuropathy, controversial topic. Another that many may know is diabetic radiculoplexus neuropathies. I really like these cases, not for the patients, but because they are really interesting. Another name for that's diabetic amyotrophy, if people know that name. There are mononeuropathies like carpal tunnel syndrome, and there are cranial neuropathies. And so I'm going to just talk about what each of those are and explain why we use the different lingo that we use. Does anybody have any questions so far? Okay. Is anybody bored? Thank you for the one big no. All right. So distal symmetric polyneuropathy, this is just a picture of what it looks like. Glove and stocking is the typical term that you hear. Now, if you have somebody that has numbness in their hands and feet at the same time, I can assure you it's very unlikely that they actually have peripheral neuropathy in the hands. They probably have carpal tunnel syndrome or ulnar neuropathy in the hands, and they probably have peripheral neuropathy in the legs. You have to have pretty extensive and severe neuropathy to start spreading up into the hands, and usually those patients do have significant weakness in the legs by that point, and very obvious phenotypes. Most common symptoms I think that patients do report, other than numbness, tingling, are the small fiber symptoms, because those are the most disabling, the most bothersome to patients. The burning pains, the shooting pains, my feet are always cold, my feet are always hot. Often they describe skin changes, and then obviously those skin changes can have a lot of different appearance, but I've had patients tell me their foot's always white, their foot's always red. And then you can get a modeling appearance as well. The large fiber symptoms are often, I find, the patients that don't really tell you they have much other than numbness, and balance tends to be the big issue with large fiber, because large fiber dysfunction is dysfunction from the lack of perception of vibration and proprioception. So these patients don't know where their feet are in space. When they walk and stomp on their foot, they're not actually feeling the ground normally. So they might start leaning to the right, and their body and brain don't know they're leaning to the right until they're way to the right, and then they try to correct back to the left. And so they have a lot of balance issues once they have large fiber neuropathy. Big thing, the first thing when you look at a nerve conduction study is the sural nerve. That's kind of the furthest sensory nerve that we would typically check on a standard patient, and that response is usually gone. So you'll see on a nerve conduction study that they do not have a sural response. That's pretty typical of diabetic neuropathy. The acronym we use for this is DSPN. So you often see that. Oh, sorry. Small fiber neuropathy is a topic that we just talked about, and sometimes patients have small fiber neuropathy without any large fiber neuropathy. Again, really painful, and usually they have a lot of temperature, I think, sensations, either one way or the other. They're going to have normal nerve conduction studies. So if you ever send somebody for a nerve conduction study and it's normal, hopefully your neurologist or whoever's doing the study makes a very clear statement that this does not rule out the possibility of small fiber neuropathy, because that test does not test for small fiber neuropathy. The only way to test for small fiber neuropathy and diabetes is by doing these fancy tests that I think serve very little utility. And the reason I do is because I think that it's a clinical diagnosis based on symptoms in the right patient. I think we can become ultra academic and do all of these great tests, but at the end of the day, I don't think it really helps the patient to do a skin biopsy and measure the intradermal nerve fiber density and say that it's reduced in the foot compared to the leg, and therefore they have small fiber neuropathy. I think it'll be managed the same regardless of the result. Likewise, we have these fancy autonomic tests where they basically put these suction cups on your skin, they infuse acetylcholine, and then they measure how much sweat you produce. And what you'll see in small fiber neuropathy and diabetics is that in their feet, they don't produce any sweat. The higher up you go in their leg, the more sweat they produce, and the hands produce the most sweat. Cool test, probably not going to change your management of that patient. And then just always remember that other diseases can cause small fiber neuropathy. So we always do want to make sure, alcohol being the biggest, I think, issue as a potential comorbidity that could be driving small fiber neuropathy and causing lots of pain. And then other rare diseases can manifest that way. Autonomic neuropathy, common, and it's usually an advanced symptom. I will say I've seen patients that have significant orthostasis maybe a little earlier in type 2 diabetes than I would think. I think it's very uncommon to see autonomic neuropathy without any peripheral neuropathy. So usually they go hand in hand. In terms of symptoms, so affects all the different organs. Cardiovascular, resting fixed tachycardia is probably the biggest issue, and that's from vagal nerve dysfunction. Orthostatic hypotension, very common. Often patients report, again, just dizziness with that type of symptom. And then exercise intolerance is really common. There could be a lot of reasons for that. These folks that have these cardiovascular issues from autonomic neuropathy are the ones that are at higher risk for perioperative complications and surgery. Gastrointestinal, I usually ask patients, do they get full really quickly after they eat? You all know about gastroparesis, so I probably won't dive into that too much. Patients do often commonly report dry mouth and also constipation from autonomic dysfunction. Skin, so we've talked about sweat patterns. Occasionally I have patients that come to me and say that I've noticed that I'm not sweating in my feet, or I'm sweating more in my feet than I used to, but that's a pretty unusual, I think, symptom for somebody to report by itself, not a common symptom. Dry skin and temperature changes are the more common thing. Genitourinary, main one being erectile dysfunction, but there are others. And then in terms of eyes, because of the effect on the sympathetic nerves, our eyes don't dilate as well. And so these patients have worse night vision as a result. I told you I really like diabetic amyotrophy just because it is a really unique presentation. It's usually type 2 diabetics. I've seen it in patients with really bad control, and I've seen it in patients that have very good control, I would say. I haven't seen it in anybody with an A1C under 6.5%, but I have seen it in patients that are fairly well controlled. The disease is kind of a hard one to diagnose initially because pain is the main feature. These are the patients I see, and they're typically in a wheelchair because the pain is so severe and they have such significant weakness from this disease. We think that it is inflammation of the little blood vessels around the nerves that triggers this disease and causes the nerves to become ischemic. They lose their oxygen supply and the nerves start dying. Typically, patients present with this with weeks to months of symptoms that start in one leg. Usually they come in with severe hip pain. Usually they get x-rays of their hip, lower back x-rays. Eventually, maybe they get a lumbosacral MRI looking for a pinched nerve in the back. That's sort of the course. And then eventually they find their way to neurology. And often I struggle when I first see them because they have such profound pain. I can't even assess their strength. They don't lift their leg because it hurts so much. But the reality is a lot of them have atrophy of their muscles by the time they see us in neurology many months later. The quadriceps, the hip flexors are all shrunk. I've seen patients progress for up to 2 years with this disease, start developing atrophy in the hand muscles, and the contralateral leg gets involved. They usually do lose a fair amount of weight, and most of that weight loss is from muscle loss. A little bit of controversy in treatment. I think I do talk about this later, so I won't right now. I'm sure everybody in here is really excited to give their diabetics IV methylprednisolone 500 milligrams, but I like to give it to them. Diabetic neuropathic cachexia. There's one patient I know with that right now. It's uncommon. I've only seen 2 cases, but it is typically a patient that is very cachectic in appearance. Again, it's a disease that presents over months, much different than the distal symmetric polyneuropathy we usually see in diabetes that's slowly progressive over months and years. This is somebody who develops really profound pain, numbness ascending, arms and legs are involved, weakness. They're usually areflexic, and usually they've lost 20, 30, 40, 50 pounds by the time they're seen. The pain can be really hard to treat in my experience. Usually they do get a big cancer workup as part of the evaluation because we're not sure what's going on. And there is no specific test to diagnose it. It's really clinical history and ruling out disease mimics. The neuropathy itself actually does get a lot better and can get a lot better, as with diabetic amyotrophy that I just talked about. So these are 2 cases where these patients do get better with good glycemic control. Treatment-induced neuropathy. I do think there's some controversy. I'd love to know what everybody in here has heard or says about this topic, but there is a general consensus, maybe controversial, that patients that have more than a 3% correction of their A1C over 3 months are more likely to develop neuropathy as a result of that fast correction. Theories include relative sudden glucose deprivation in the nerves. Again, nothing is, I think, pathophysiologically proven. The management's also controversial. I was reading through studies that talked about how patients did. And basically, the question is, do we allow these patients to have permissive hyperglycemia when they develop this and just let them have a little bit of poor control for a while and then try to reel it back in slowly over many months, per se, over the next year? Or do we just continue to aggressively treat them for their diabetes? I think the answer is we probably should continue to treat them for their diabetes. And I think that these patients have been shown to have near complete functional recovery when they develop this really painful treatment-induced neuropathy, if we continue to treat through it. And so often we treat them with symptomatic management in neurology, but we continue to recommend aggressive treatment rather than taking our foot off the gas. People who have elected to go with permissive hyperglycemia in one study over 2 years tended to have a persistent neuropathy in the aftermath and didn't fully recover. Mononeuropathies. So these are really common in diabetes, and these are one good reason we do recommend nerve conduction studies, and certainly patients that have symptoms in their hands, which I'll talk about later. Cranial neuropathy, the most common one, is an oculomotor palsy. These are their patients that get a down and out eye. You probably don't hear about them because they're in the emergency department and they're getting ruled out for a stroke in most cases. The other facial neuropathy, Bell's palsy or facial neuropathies, can occur as well in diabetes at an increased incidence, and other cranial neuropathies can occur too. It's usually eyes, so usually double vision is what patients report. Compressive neuropathy is very common. So general population, 3% of people have carpal tunnel syndrome, almost 15% in diabetes, so 5-fold more common. Ulnar neuropathy is also seen at a higher rate. In diabetics that already have peripheral neuropathy, about 1 in 3 have carpal tunnel syndrome. A lot of them don't have any symptoms, and I don't always treat them if they don't have symptoms, but I find it all the time when I do nerve conduction studies that they have mild to moderate carpal tunnel syndrome. Sometimes I see people who have completely shrunk and lost all the muscle in their thumb, and they can't oppose their thumb because they've atrophied a muscle and have severe carpal tunnel, and they don't have any symptoms. They don't tell me they have any symptoms. Those are people I usually do end up doing something for and recommending surgery. But for people with more mild carpal tunnel that are asymptomatic, we don't always do anything. So I think the question that a lot of people have is, does it get better? And I think that the answer for traditional distal symmetric polyneuropathy is it probably doesn't get much better with treatment of diabetes. The goal of treatment I always talk to patients about is the goal is to actually halt the progression of the neuropathy. It's very unlikely to change the progression and the course of the neuropathy just by glycemic control. They have countless studies that have looked at the actual electrodiagnostics of the disease and looked and seen, have they gotten better over the course of time with aggressive treatment? And the answer is only in a few have they shown mild improvements in the amplitudes of the electrical responses that I talked about earlier. But generally speaking, the goal is to halt progression. Pain, however, I tell patients is the thing that we really can improve. And I think that's probably the most disabling thing for most patients, that temperature sensations and pain can result in people having falls and balance issues just because that pain is so debilitating. And we can usually help the pain either through glycemic control or through medications that we use in neurology. And they're often just used temporarily. And then the entrapment neuropathies like carpal tunnel syndrome can definitely be treated and can definitely result in improvement in symptoms in the hands. So I said there was a little bit of controversy. I am always curious to see what our folks over in endocrine think about this topic, because I was told as a medical student, prediabetes causes small fiber neuropathy. That's why many neurologists order a 2-hour glucose tolerance test when we suspect that somebody may have small fiber neuropathy. And we recommend often dietary changes, lifestyle changes, or consideration of metformin in our notes when patients have small fiber neuropathy and they have glucose intolerance. However, I will say that a recent publication from a journal that is a very high quality journal from Muscle and Nerve investigated this question and came to the conclusion that diabetes, but not pre-diabetes, is associated with small fiber neuropathy. So they don't think that it causes small fiber neuropathy, and they weren't able to prove patients with skin biopsies had any abnormalities with pre-diabetes. So I'd say the controversy continues, but we might be wrong, and it might not actually cause small fiber neuropathy. So that's on us. We'll try to be better. For treatment, I know everybody here is very aware of how to treat diabetes much more than I am. The only thing I think I know now is Ozempic, because everybody is on Ozempic. I just learned a lot about Ozempic in the last 6 months, and I didn't know about it before 6 months ago. But there was the diabetes prevention program study in the past, I think made a couple takeaway points, which is one, that lifestyle intervention reduces diabetic incidence in people that have impaired glucose tolerance, and that some people get better on their own, even in placebo treatments, and people that have glucose intolerance 3 months later, 6 months later, despite just getting placebo treatment, no lifestyle change, end up getting better. But I do emphasize that I think everybody in here will agree one of the hardest things, but best recommendations, is going to be diet and lifestyle changes for prevention of progression, because we know that there's all these neurological conditions that can develop as a consequence. For treatment ideas, I don't know if anybody in here typically treats diabetic neuropathic pain, or if they have favorite medications that they like to use. I prefer SNRIs. I really like SNRIs because they have very little side effects. And that's just my experience anecdotally. It's not universal, but I very rarely have a patient start duloxetine and come back to me and say, I'm having a side effect. Whereas medications like gabapentin certainly have side effects. And I think we've all seen patients on gabapentin have significant weight gain, lower extremity edema, cognitive side effects. So while it doesn't affect everybody that way, I certainly like to start with something that, in my opinion, is a more benign treatment option. So I usually start with duloxetine or venlafaxine, and I will take duloxetine, for instance, up to 60 milligrams. If they're not having any improvement at 60 milligrams, there's really no point in going to a higher dose. I only go higher than 60 milligrams if I think that there's a really concrete response. What I usually try to use is a pain scale for patients, and I ask them what their pain is beforehand, and then we clarify what their pain scale out of 10 is afterwards. I do think it's really important to tell patients that the expectation is very rarely cure pain. We aren't going to see 8 out of 10 pain go to 0 out of 10 with these medications. And I think true with any pain disorder, setting that realistic expectation about what the goal of the medication is really important, because otherwise patients do stop the medication, say it's not working. And I often have to really emphasize that you're starting at a low dose. We're going to be careful and start at a low dose and not escalate too quickly. And we're trying to reduce the pain. If you're 8 out of 10, our goal might be 4 out of 10. I like to use gabapentin at night if I'm using it, because a lot of patients really have pain at night. And they say during the day when they're up and about and their brain's distracted, they don't really notice their pain. But when they are sleeping, the blankets and the sheets irritate their feet and cause really bad electric pains. And that's what keeps them awake. Like any pain disorder, when we're trying to sleep, that's the hardest time to block out pain. So I will use gabapentin at night often, just because it can help with sleep and it can help with that neuropathic pain. Lyrica is another good option if they fail gabapentin. Tricyclic antidepressants, nortriptyline and amitriptyline work great. I'm always trying to treat different diseases as a neurologist, and I often have migraine patients who have neuropathic pain, so I'm trying to treat 2 different conditions with one medication. So I do use nortriptyline frequently. Just remember that it's anticholinergic and it can potentially be problematic in your patients with autonomic neuropathy, patients that have resting tachycardia, for instance, that may get worse, and they may have worsened exercise tolerance as a result. Alternatives. So creams are awesome. And a lot of patients really don't want to be on a, medication that they take by mouth every day. And so creams often work for a lot of patients. I usually use lidocaine cream, 5%, and hope that it works. And patches can be used. Between menthol cream and capsaicin cream, I generally ask patients, do you have hot feet or cold feet? If they have hot feet, we go with the menthol. If they have cold feet, we go with the capsaicin, kind of counteracting the symptom that they have. There are some studies showing that TENS units can be helpful for neuropathic pain. Again, it doesn't heal the nerves, but it can be helpful for the pain. And another kind of point of controversy is alpha lipoic acid. Again, I don't typically start or recommend that, but when patients are asking for a more natural source for pain relief, then I do suggest alpha lipoic acid, which in some studies showed some improvements in pain, but it's not a consistent finding in all studies. Unique treatments, yes. IV methylprednisolone. So for diabetic amyotrophy, I promise not common, but when it occurs, these patients are crying in pain. These are patients who are really miserable, and this pain can last for 1 to 2 years. I saw many, many cases in my fellowship, and virtually all of them were in a walker or a wheelchair, really disabled, really significant muscle atrophy. And I can say confidently that all of them had dramatic pain responses to steroids within 2 infusions. So typically what we do is 500 milligrams. We do it once a week. We do it for about 8 weeks. And we promise to tell our endocrinologist sorry in advance and let them know that we're about to do this because it will obviously affect their diabetic treatment. But I've yet to see a patient who didn't have a dramatic improvement. Now, I have had complications occur, unfortunately, as a result of this treatment. So I don't mean to say that it's benign. But I see people who continue to progress with this disease and lose the ability to walk and care for themselves and get up staircases, for instance, without that treatment. It was studied. I think there was a study done at the Mayo Clinic probably 20 years ago, or maybe even 25 years ago, and they did not show improvements in the electrodiagnostics with steroids, but they did show that due to pain relief, patients had performance improvements, so able to walk further, which they attributed again to pain relief. Autonomic neuropathy. So I always start by looking at medicines, make sure they're not on any medicines that might be causing the issue. So always important, obviously, to make sure we're not doing it to the patient with something else. I always start with non-pharmacological strategies because so many of these patients have comorbidities like hypertension that make these medications more risky. Compression stockings work great for orthostatic hypotension, but you got to remember it has to be above the knee. It's basically been shown to be minimally effective if you wear below knee compression stockings. So it's either got to be above knee or an abdominal binder with below knee compression stockings. A lot of patients don't like wearing them and they find them very uncomfortable, unfortunately. I usually encourage patients to try and chug some water right before they stand up. Just by chugging about a half liter of water, you'll have about a 10 millimeter mercury improvement in your systolic blood pressure that lasts for about an hour. And so something like that sometimes is all you need to do just so that they don't get that postural dizziness when they first stand up in the morning. All of these other ideas are just ideas to improve venous return, like raising the head of the bed at night, prevent loss to the kidneys, and a few other things that are just acute interventions to make before standing. I don't usually use salt tablets because these patients are usually not good candidates. And then midodrine and fludrocortisone are options in patients that don't have uncontrolled hypertension, but we have to remember that both of these medications cause supine hypertension. Midodrine can't be given right before bed, for instance, and I really aggressively follow blood pressure in patients and make them record their blood pressure for me when I start these medicines. I like Protastigmine. We use it in neurology for myasthenia gravis. It's super safe, acetylcholinesterase inhibitor, and I like it because it doesn't affect blood pressure. So I often will use it for that reason. So yeah, what should you do? So for, classic distal symmetric polyneuropathy, so somebody with slowly progressive numbness in the feet, sometimes associated with pain, sometimes not, or small fiber neuropathy, I believe the American Diabetes Association guidelines say that you can make a clinical diagnosis based on the things we talked about previously: absent or reduced ankle reflex, loss of vibration, loss of 10-gram monofilament perception or proprioception, and you don't actually need to refer them for a nerve conduction study or an EMG. However, we are happy to do these. We are happy to see patients, especially if they have atypical symptoms. So anybody who has any degree of weakness on your examination, to me, that's atypical and we need to work them up. Anybody who's falling, anybody who's got bowel bladder issues, or what you perceive to be quicker progression than expected. For monomi-like symptoms, meaning single extremity, probably not diabetic neuropathy. And so if somebody says my left foot's numb, my right foot feels fine, or my left hand's numb, my right hand feels fine, it's probably not going to be diabetic neuropathy, and it's probably going to be an entrapment neuropathy or maybe a pinched nerve in the back. But those patients definitely will need a nerve conduction study and an EMG. And then for upper extremity symptoms, again, we talked about the vast majority of people with numb hands and diabetes, they don't have peripheral neuropathy in the hands, they have carpal tunnel or ulnar neuropathy, and those are both treatable. So those are good patients to refer for these tests. And for everything else, call us, refer. I don't have anything else, so please, I hope that was helpful, not too boring. Ask me any questions you guys have. Oh, yeah.
Is autonomic neuropathy, is that reversible or not?
The question is autonomic neuropathy reversible? No, that's the short answer. I think with treatment, it can be reversible in that we see improvements in orthostatic vital signs when we treat patients with medicines like midodrine or fludrocortisone, but we don't see autonomic testing improvement other than that. I don't know of anything that improves, for instance, the cardiovascular manifestations. And then obviously gastroparesis has treatment. Presumably that does improve, objectively, but that's with medications, not necessarily diabetic control. And just a reminder for orthostatic hypotension, you want to make sure your patient is laying flat before you check it. You want to make sure that they've been laying flat for 5 minutes, and then you're going to check a systolic and diastolic blood pressure, heart rate, have them stand up for 3 minutes, and then repeat those. One thing I just want to emphasize is that when we do autonomic testing in these fancy autonomic labs, all the time I see patients' blood pressure plummet within the first minute, and then it renormalizes by 3 minutes. Really common. We use a finger sphygmometer that gives us the pressure every 3 seconds or so. And so these patients' blood pressure plummets by like 40 systolic, and then it comes back up to 16 systolic below where it started. And so their test is technically negative, but obviously that causes symptoms. And so their symptoms, I think, are classic. That may be the case, that their blood pressure is dropping quicker.
What are your thoughts on things like incorporating like alpha lipoic acid or L-arginine to try and decrease homocysteine? Well, not to deep, but I mean, in combo with like zinc and vitamin B12 complex and all of that too.
Yeah, so I was asked questions about alpha lipoic acid. What was the second substance? Sorry, what was the second one that you asked about?
Oh, it was just like, so I mean, I've read different studies on like alpha lipoic acid versus L-arginine in combo with like B12 complex, folate, and even like zinc and magnesium. And I guess the whole idea is that it's supposed to, all of those things together are supposed to like decrease homocysteine levels in the blood, which should help, should give nerves potentially a chance to heal, I guess, is the whole theory behind it.
Yeah, I think I'm going to just summarize as a number of different, I think, safe natural treatments that are used to lower homocysteine levels and improve nerve health as a result. I don't know about all of those. And so I will say that I am always on board with homeopathic strategies or safe strategies for treating people. I know that things like alpha lipoic acid, 600 milligrams daily, have been studied in literature, and we haven't seen objective changes in electrodiagnostics, just in pain perceived by patients. I always tell people time-limited trials of these things seem like a great idea to me. But I think at the end of the day, I'm not sure. In neurology, we used to associate high homocysteine levels with stroke, and we used to put patients that had low homocysteine on vitamin B complexes. And that was something that later was not shown to be beneficial, but again, it's not harmful. It might not be something that I tell patients to buy with their own money. That's what I always try to recommend to them, is that we stick with things. If there isn't overwhelming evidence that they're curative or improve symptoms, then we try to stick with things that are free. I take it you use those.
So I've prescribed like Metnix for patients before. A lot of times it doesn't get covered because it's considered like a medical food.
Okay.
I sell at my office, it's called Neurex,
Okay.
which is just basically a B12 complex, folic acid, and L-arginine. And I tell patients, like, give it a minimum like 4 months.
Sure.
Because it's going to take a while to work. And some patients notice a difference with it. Some patients don't. I figure it can't help, it can't hurt anything.
Sure.
At least they're getting those supplements. But
yeah,
I was just, kind of curious what your take was on that.
Yeah, I mean, I like limited trials, and the reality is the medicines that I'm using do have side effects. Patients might have comorbid depression. I'm putting them on duloxetine, and now they're at risk for serotonin syndrome because they're already on another serotonergic medicine. So I think that sounds like a reasonable plan.
Any more questions?
I have one question. My question is about the differentiation between exercise intolerance and autonomic neuropathy versus DSPN, the numbness and pain. So at the clinical level, for people who are not neurologists, what would be landmarks that would differentiate?
So the question is, in terms of the specific symptom of exercise tolerance, what symptoms I think might help point towards the etiology of the exercise intolerance, whether it might be autonomic dysfunction, whether it might be manifestations of the distal symmetric polyneuropathy. I think you have to ask a lot more questions is what I say. And I usually have to just spend more time getting clarification from patients as to whether their exercise tolerance is truly cardiovascular, or whether they are having exercise intolerance because of their neuropathy. And so I'll probably focus more on the neuropathy end of things. And if they have numbness in their feet and pain in their feet, I ask them specifically, you know, do you stop exercising or limit your exercise because of the pain in your feet? Clinically, if they have significant large fiber sensory loss, that affects balance. We know that affects balance. And so again, I kind of ask clarification questions to figure out, are you not exercising because you get tired and fatigued and winded, or are you not exercising because your feet are numb and your balance is impaired and you feel less motivated to walk because of that symptom? And I mean, certainly people that have weakness in muscles, obviously that is something you'll detect on exam and be able to diagnose.
Okay, thank you. And I think we're up for time. Thank you, Dr. Banks.
All right, thanks
And you'll
everybody.
see lots of referral coming for nerve conduction studies.